If you're looking at what research needs to be done in channelopathies, it starts at the identification of what kind of channelopathy, like the long QT syndrome, or like long QT 1, 2, or 3. There are 13 different long QT syndrome genotypes. And then there's the Brugada syndrome. There are early repolarization and J point type channelopathies, and certainly catecholamine-dependent ventricular tachycardia. Another one would be a calcium-dependent polymorphic ventricular tachycardia. There are probably 4 different kinds of those. So those are a number of different channel abnormalities, a number of different genetic abnormalities, and we don't know very much about any one of them, but we are learning. We know that long QT syndromes can occur either because of abnormalities of sodium currents. So there's an overexpression of sodium currents or ingoing sodium currents. Long QT syndromes could also be because of a reduction in outgoing potassium currents. So either way, it prolongs the QT interval and can lead to sudden death. Best approach to long QT1 and long QT2 is to treat with beta blockers unless they've had an episode of sudden death. Long QT3 is different. It's because of the SCN5A abnormality. And when there is an abnormality of that gene type, then the QT interval can be very long. Mexiletine and flecainide both work very well in reducing that sodium current that's responsible for that long QT interval. Induced pluripotential stem cells that can be used to recreate the mutant abnormality and then treat the abnormality. A number of those studies, including some by Silvia Priori, where they used adenoviruses that had been gene loaded. Now, there's 2 ways you can do that. One is to put in an abnormal gene and create the defect. You actually create the abnormality that occurs within the cell that causes the channelopathy. What she's demonstrated is that she not only can reproduce the abnormality or the mutation, is that in using repaired genes or normal genes or wild-type genes, she can load those into a vector or an adenovirus and introduce those into the cells and reverse the effect of the channelopathy that creates the problem. Now, there are a couple of those. One is a ryanodine receptor, and the other one is a calsequestrin apparatus, and both of those can be repaired in order to correct the problem. The next step needs to be, again, finding the diagnosis, identifying the gene, getting a target gene in place to replicate the abnormality, and then finally getting a gene in place to reverse the abnormality. So I think that this is a great period of time right now because we're to the point where we know a little bit, but we're working on topics so that we'll know a lot. And I think that those topics will be centered largely around gene manipulations, around iPSC type protocols, and other approaches.